ist das Screenshot. Jetzt geht's.
Jetzt geht's, okay. Aber jetzt dann müssen wir das wieder rausmachen, ne?
Ja, genau, jetzt muss das eigentlich gehen. Okay.
Hello everybody. Aber wenn es ohne das geht, ist es okay, oder?
Nee, geht so.
Geht so?
Ja.
Okay. So, yeah. Thank you for the invitation to Dublin. Thanks for the introduction and thanks to be here. I will talk about this just minimal invasive treatment to lengthen the shortened fascia. We have several possibilities for soft tissue surgery. We have tendon transfer we can perform. We can do an intramuscular lengthening, but today I will focus on the percutaneous technique. The idea is that I cut with a special knife through the skin the shortened fascia. I don't damage the functional muscle. I have no large incision. And I can perform many corrections in a short time. Here again, I have a low loss of blood, minor scarring. There are low intraoperative risks. I can principally do a reoperation, and I can, if it's necessary, combine the whole thing with bony correction. And finally, I can perform it ultrasound guided. This is the idea. Here I have a shortened muscle fascia. I go through the skin with this little knife, cut the fascia. And in a general anesthesia, I just do a lengthening. And after a while, there will be a stable situation in the fascia, but no damaged muscle and no damage way from the skin to the muscle. And this is the idea with the simulation. This should be a healthy muscle with a good movement. And then this muscle with the shortened fascia here. And there's still a little movement, but not a good movement. And then I go with this little knife through the skin and do the lengthening. And finally, I touch maybe the surface of this healthy muscle, but I don't cut him. And afterwards, I have a lengthening of, for example, 1 or 2 centimeters in this area. This is the preparation. We have just to mark where we do the treatment. We can almost treat the whole body. And this is the instrument table in the operation theater. And everybody who saw who was there, who saw documentation, this is not a lot of instruments that we need. And this is the video where we perform the lengthening of the hamstrings. So there's one guy who puts the whole system in a position, and one guy is doing the lengthening. And you can see it's a feeling with the fingers and a feeling with the knife. And afterwards, there's only a little skin puncture. And if we don't feel any shortening anymore, we stop the surgery and we are in this area done. Another example, this calf muscle, very often a problem after an accident or a stroke or blooding. And this is an original video from the operation theater. It's about 30 degrees that we want to, where we need a correction. And then you go in with the little knife through the skin. And you can see here how the knife jumps over the shortened fascia. And then I do, with the other hand, the feeling, and this case, we needed another function, a little bit more down. Yeah, you see the knife is jumping. And afterwards, I have a correction about 10 degrees over the 0 position in the ankle. Yeah, and this guy gets a cast, and the next day he's allowed to walk. This is the aftercare in the arm, and this is the aftercare at the leg. These are special soft cast orthoses, and sometimes in the hand. And if even seen, this is the scarf after just some months. These are the patients in the last years. You see, we have about 6,000 patients, children, grown up and adult patients. And even in the years of the pandemic, because it's a short operation, it's no high risk. We performed a lot of those surgeries, and we also split often treatment of the arms and the legs. The first time we did mostly both together, but we find out that sometimes it's easier or it's better for the patient just to split it. First treatment of the legs and then the arms. These are some results. We see a better movement actively and passively of all the treated ankles. We have seen no overcorrections, functional improvement, and the recurrence depends on the function after the surgery and the spasticity, and especially in the children, the age of the patients. And normally it's like the grown-up or adult patients, we don't see any recurrence in the treated muscles. We also have some complications, but the complication even in the vessels and the nerves, but finally it's not more than complete compared to the old techniques. And these are some subjective results from our patients. Better talking, even if we don't did anything in the face or the mouth. Increased walking distance, no salvation anymore, better using of the arms, more self-confidence, back to work, back to life, can use the hands better, and yeah, thank you for my food. Have you been the surgeon? Again, comparison of the techniques we know. The set-shaped lengthening of a tendon, it's all red because it's a long aftercare, often overcorrections, and usually only in some cases we need this. The open intramuscular technique, it's a little bit more green, but finally, from our opinion, the percutaneous treatment, it's the best for the patients, and we have extreme short-term immobilization, hardly no pain. The adult people say it feels like just muscle pain after a longer walking distance. We don't injure the sliding fabric, and we have a very, very short surgical times. Some clinical results. For example, this is a hand after stroke. Relaxed, open, but he cannot open it again. It was a painful situation for this patient. And this was the result after 1 year. And this result after 3 years. He's coming once a while in our hospital for a conservative treatment. And he can use this arm now for a good helping hand compared to the situation before the surgery, where it was only painful. This patient had only 2 fingers problem here before the surgery. And then after the lengthening, was able to move and use all fingers again. Or this girl, she was walking on a his equinus varus. We did only a lengthening percutaneous of this calf and the tibialis posterior. In former times, we would have performed a transfer. This is 3 months after the treatment. And especially she could stand on one leg, on the left leg again. He couldn't do it before. And I saw her 3 years after the surgery, same foot position, no orthosis, good walking distance. But you can see that the muscle of the calf, not because of the treatment, but because of her basic illness, is still very small. We also perform some scientific work. This is a guy, we did a lengthening of the muscles in the leg. Do it again. And he was working on his toes, and then after 1 year, normal walking, and he's still normal walking. And this is a patient, he was almost, he lost a lot of blood, and he had a circulation stop, and then he was reanimated, and he was very contract. And we performed the lengthening first step of the leg, and this was the treatment afterwards. In the first pictures, they show the whole the situation. There was no movement anymore in the legs at all. This was after some months in the walker, how do you call it? The locomat, yeah. And then after a while, walking with some help. And this was the first time I saw him after the surgery, 6 months during a meeting. And he was able to walk again with little help. And then another rehabilitation session, he was much easier for him to walk. And then we performed treatment of the arms. This was the situation before. And this was the situation afterwards. He could use his arms again for eating, and the left hand better than the right hand. And so he came step by step back to life. And this was the last picture I saw from I got from him. And this is a patient, he had a stroke and had problems in both legs. The hamstrings and the calf was shortened. You can see here, similar on both sides. It was immobile. It was immobile for, see as well, immobile for some months. Here again, with the hand, he wasn't able to communicate anymore. And then we performed the percutaneous lengthening. And this was the video I got after 3 months from the colleagues from Bad Aibling. It's a sister hospital of us. And I thought, oh, well, now he can sit and he can move his legs a little bit and his toes. And then there was another video. This was this. It was the same guy walking without any orthosis, walking without any help. And before the surgery, he was not able to stand or walk anymore, and I think he came back to talking again. And if you have a little this is a video of 3 minutes, and this is a guy, he had both. He was born with a cerebral palsy, and then he had a stroke as well. And I got to know him in this situation, with the leg not able to walk anymore, and standing was very hard. And his family said, no, we don't want the surgery. And he said, I want the surgery. I want to learn walking again, or I want to go back to walk. And he, in the past, he was walking just a little bit on his toes. And this was after the surgery, the first video session. Here you can see also the cast we put on. And this shows how important the rehabilitation is for the patients. Yeah? Only perform a surgery and then going home without anything, it will not help at all, or not help for a longer time. And then after some weeks, he was able to walk in his room, go to the bathroom alone, come back. And he said that walking before the stroke wasn't that good compared to this situation. Then he was on the steps, up and down. And after some months, he was able to stand and walk with normal shoes. And this is no positive selection. All the videos are, many of them. And this was a golf trainer. He had a blood circulation stop and brain injury. He's still a very young guy. He was in the rehabilitation hospital, and at the beginning it was very hard for him to hold his head, and then he did the rehabilitation, but he still had some problems with the muscle fascias and legs. And then we performed the lengthening, and these were the first walking steps afterwards. And because he was a golf trainer, he wanted to go back to his work and to his normal life. And in the meantime, he was on the bicycle, and he got married, and then he sent those pictures. And finally, this video. And he told me, whenever it's possible, just show the picture, show my way, because I'm back to my life. I'm working 100% as a golf trainer. And whenever you want to learn golf, then I should contact him. Yeah, the percutaneous muscle fascia lengthening is a fast operation technique. We have less post-surgical pain, shortened recovery. We can combine it with bony corrections, and we have very high acceptance by patients and parents and the families. The midterm outcome indicates that there are persistent corrective effects with improvement of individual function and significantly improvement of quality of life. The postoperative adjustment of the toes is more feasible, and in some cases that we want to avoid, we need different soft tissue management or even bony corrections. With laughing of our hospital Harlequins and some pictures of Munich. I thank you for your attention.
Any questions?
I'd like to ask a question. Just if you cut the fascia to lengthen the muscle, does the fascia grow back normal?
Yes, that's what we think. It's like it's compared to the open technique, it's much more normal. It's close to normal. Yeah. But even in children, we perform in some cases after 3 or 4 or 5 years the treatment again, and we don't feel where we were before. So that shows us that we are right. And in the adult people, in patients, after some months, it feels like very normal. Yeah. And I did several years ago, we did an MRI, just examination before and afterwards, only in 2 cases because of the money, but in both cases, the radiological doctor said there's nothing to see from this surgical treatment.
Can I ask you if you're correct and lengthen the muscles to maintain the position in a cast for as you said, you walk, you're able to mobilize the day after, but
yeah.
Would you sometimes be afraid that they fall back, or are they splinted then when they're sitting?
We are, in some cases, we are a little bit afraid that there will be an overcorrection without the cast treatment. And it will be the mobilization with the cast is much more easier for the patient, and maybe a little bit pain lesser than a little bit less pain compared to without. But always, if it's possible, I don't use a cast.
Can I just ask, is this technique done only in Germany, or is it done?
Pardon?
Is this technique done only in Germany? Or
No, the thing is, basically, it came from Mr. Ulzibat. Ulzibat, he was from Russia, and one of his, he taught a guy called Nazarov. He is in Barcelona doing the same. It's not the same because his aftercare and after treatment is a little bit different. We started 2008 with this technique, and we developed our own way. And there are some hospitals in Germany, almost all children orthopedic surgeons have been to us, visited us, took a look, and we showed everything, and some do it as well. Some say, oh no, I don't want this because I'm not sure if I can perform this without any risk for the patient. And there are several other countries where there's mostly one hospital that performs this.
How do you control the nerve not?
Yeah, so we know that the nerves for the muscles, so the motoric nerves, are very deep, and we avoid to go very deep. Sometimes we have a little bit problems with the skinny nerves. For example, the suralis, if we have a very short calf, then we have this mobilization, and sometimes the nerve is a little bit affected, a little bit beleidigt. What's this beleidigt? Yeah, for a short time, but usually it comes back. And we have only some nerve problems with 6,000 patients, and it's very only some.
But you mentioned that you repeat it sometimes when you're dealing with children, child
Yeah.
patients. When you perform it on an adult patient, what's the life expectancy? How long will it last?
It depends on the function, and it depends on, for example, that's what I told that for grown-up or adult patients, usually it stays for the whole life.
For the whole life.
Yeah.
Okay.
Sometimes other fascias or muscles are affected and shortened during development. So even in the children, we perform this technique 2 or 3 times when we start very early. And everything is good when they're grown up, and after some years, I got a call, and then, for example, the toe flexures, where we never addressed, are shortened because of the spasticity. And then we do a treatment here, but it's compared to the other treatment, it's a very small treatment. And but in the adult patients, most of the time it's only 1 surgery, and then it's good.
Could I ask you again, if you make the indication for the surgery, so do you have a neurologist, or well, you have the experience now, but I found it difficult in a few cases today. You said, okay, go for surgery. then on somebody else, you said, oh, you need a baclofen first,
Mhm.
just to avoid any recurrence. But so is it the spasticity you assess, and you're afraid that your surgical correction will fall back into a recurrence?
So usually the patients are sent from the neurological doctors in the adults, from the hospitals like neurological rehabilitation hospitals. And the children, they usually come from social pediatric center, where the neuropediatrician is taking a look about spasticity. In some cases, they come to me and they have no treatment for the spasticity, and then say, okay, we need this. But most of them have it got it from the children doctor or from the neurological doctor before.
Is there any like precautions for the rehab afterward, or can they get on their feet straight away? Is there any limitations for therapy afterwards?
Yeah, normally not. It depends on the experience we have. Usually I see a lot of patients and I know I can perform this. In some cases I say, okay, we tried in this very percutaneous fascia technique, and if it doesn't work, then I go to the tendon. But also minimal invasive, and also with the possibility of standing and walking the day after the surgery.
What do you think about compare this technique with
The open technique?
with the casting and put it in the mouth?
Yeah, this is often before, and some degrees it's possible to correct with casting and botulinum toxin, but especially for me,